Recording in progress.
Good morning, everybody. Thanks for being here. Dr. Leslie, thank you for doing morbidity and mortality. Thanks for everybody's participation. It gives me great pleasure to introduce Dr. Leslie as our grand round speaker this morning. Dr. Leslie is a graduate from Medical School, New Jersey, Robert Wood Johnson. He matriculated there from Dartmouth University, and we were very lucky to have him come here. Dartmouth College, I apologize. And the Dartmouth College. and then to come here to spend his time as a resident, during which time he spent several years in the lab, 4 years, I think, with David Dunn, who was the chair at the time. He quickly and inexplicably developed during his residency an interest in bariatric surgery, and did a fellowship in that, and really, I think, has become a national leader in this field, in my opinion, without question. He leads the program and has led the division of gastrointestinal bariatric surgery, and one of the hardest working surgeons that I've ever met. The interesting thing is sort of this probably mid-career embracing of health services research and leadership that you have. He's our department leader in Cosmos, Epic Cosmos. I think you've all, if you haven't, soon will hear about the importance of Cosmos in helping us to generate decisions that will help inform clinical decision making, and it's really made a tremendous leap forward. And he's here to talk about, is there a role for bariatric surgery in 2026? This is an interesting question. It's an almost existential question today. This is a field that was born really at the University of Minnesota, as were many cardiac procedures, as were transplant procedures. It was born here, and if you look at the wall, you can see the originators of bariatric surgery. It all came from here, and so that it is somewhat interesting to have that conversation today in this room. At this year's American Surgical Association, there was a really interesting paper that was presented, and it's sort of looking at the demand shock of GLP-1s and these medications on what it's doing to the practice of bariatric surgery. And it was interesting. I had an opportunity to comment on that paper. It's much broader than we think. We think about the effect of GLP-1s on bariatric surgery. Let's also remember that GLP-1s are going to reduce cancer. GLP-1s are going to impact a lot of other diseases that we operate on, and may in fact impact renal failure. So even the transplant surgeons should be taking heed of this. But I think I'll just leave with one additional comment, and I hope you can address that after you're doing the read there. Is that we have clear evidence that bariatric surgery and the medications are not the same. When you put a patient on a GLP-1 analog, when you put a mouse on a GLP-1 analog, their brain will light up in all areas, almost like a Christmas tree, if you will. That's not an exaggeration. That is not the case for patients who have bariatric surgery. In fact, if you knock out in mice the GLP-1 gene, you lose weight just fine. It has more to do with the ventromedial hypothalamus. So it's possible these are complementary therapies. It's possible that they may have completely different functions altogether. And I'll leave you with one thought. I use some time while Dan's on the phone there. There was a very interesting paper that looked at the polymorphisms of the GLP-1 receptor in Nature just a few weeks ago, showing that those patients who do have polymorphisms in that are less likely to lose as much weight. So, and that would make sense, right? If you don't respond to it, if you don't have a receptor for it, you don't lose as much weight. And so I think that given our ostensible need to move toward precision medicine, this really is going to be an important question as to where is so much bariatric surgery have a role, but where does it fit in the therapy for this very chronic illness, deadly illness of obesity? Dr. Leslie, thank you.
Well, thank you very much. I was actually in this very room in 2003 when Ed Mason, who was also a graduate of this program in the 1950s, spoke. And he said that there will be a need within a few years for 1,000 surgeons doing 1,000 operations a year. And it hasn't quite come to that. That was right in the day when the fen-phen craze had just blown up, and all those medications were removed from market, and there were no options. And with the obesity epidemic as it was, things had changed quite dramatically. I have no disclosures. The answer to the talk is yes. I just did a brief to do a sleeve gastrectomy. I have another sleeve gastrectomy to follow. The problem right now is that the exact role and how it plays inside an increasing armamentarium of options is, I think, most important. Trying to define that role is going to be critical. And I think we have some tools that allow us to do that. I'm going to try to really talk about those tools. In fact, I'm not going to spend a lot of time talking about some of the data from the past. I'm going to spend a little bit more talking about how we can get data for the future. And you can start to think about what we can pull from Epic Cosmos, from other databases. That's why I asked the question about that procedure, the complicated procedure. How do you define a way where you could do a clinical trial in a situation where you can't do it? You can't do a randomized study of patients, of people jumping out of an airplane with or without a parachute on, except that they have done it. And it shows no difference if you jump from 5 feet. But if you jump from high up, there's probably a difference, and you have to find the data rather than creating the data because it's not ethical. I'm going to talk a little bit with some murdered slides. I guess this was designed to create a, what is this? It's a BMI equals. Okay, so BMI, people keep asking, why do we keep using body mass index? Aren't there more sophisticated things that we can do? And my response to that in general is that body mass index is incredibly cheap and easy to calculate. It makes sense for a lot of people, and the problem that we have inside the electronic health records is we don't have a way to contextualize it completely. So a patient who has a BMI of 41, and they show up in their primary care office and they say, you have obesity, you should lose weight. And the patient is thinking, wait, I had a gastric bypass last year. I'm 130 pounds down. How much more weight should I lose? Well, you have class 3 obesity. That patient whose BMI was 60 and is now 40, 41 is in a really good place. And a patient who had a BMI of 28 and is now 31 with new emergent type 2 diabetes is in a much worse situation. And so contextualizing body mass index, having a way to reframe that discussion, those tools aren't readily available, so putting BMI into context is absolutely critical. So highest lifetime weight, are there medical problems? We're not targeting ideal body weights, which are based on life insurance tables. Life insurance tables that are really based on whether you die or not in a term life during a term life insurance policy, not what your health was during that term. There are three recognized categories of obesity: class 1, 2, 3. There are probably some subclasses now where they talk about class 4, BMI 50 and higher, class 5, BMI 60 and higher. Nonetheless, these three remain extant. It is a disease. Anybody know here when it was called a disease, finally? It's always been a disease, right? Dr. Leishman, you're about to enter Bariatric Allied Fellowship. 2012. Before that, it was just gluttony and sloth. Okay? So it became a disease after the Affordable Care Act went into full implementation. And so in most states, essential health benefits may or may not require payment for obesity care services. And in most places, the answer is no. In Minnesota, there's no requirement that insurance companies pay for the central driver of all of these different disease processes: cancer, metabolic disease, joint disease, diseases of inflammation. Well, what about mortality? Well, we know from 1999, a paper in New England Journal of Medicine, that when patients have higher BMI, their mortality is higher. And we know there's an exponential curve related to that. When you look at a curve like that, you probably ask the question, well, if you slid back down this curve, if you came from here back to here, does it also then change your mortality? Or is it simply fixed based on where your BMI was at a certain point? We can talk about prevalence, but most of us have looked at these heat maps, which are based on telephone survey data. Everybody is a little bit taller and a little bit lighter on the phone than they are in person. And so these generally underestimate the prevalence of obesity in any state by 5 to 10%. The real data are based on the NHANES data set on the right side here. You can see that at least in the 2017-18 era, the obesity rate was 42.4% in the United States. Has there been a leveling off of that? Difficult to know, but it's statistically about the same as that right now. In Minnesota, you can see, at least on the telephone surveys, what happened with obesity rate: 10% in 1990 and 30.7%, at least on the telephone, in 2020. And so forth. The data are quite clear. There is probably a difference between same BMI patients having unhealthy fat and healthy fat. I'm not going to talk much about that. In fact, I'm going to get to the slides that I really want to go to, which is all the way to the end. We're going to skip the benefits of weight loss, all right? That's a bunch of slides. We're going to skip physiology of food intake and strategies for weight loss, all right? Hope, lifestyle, medications, surgery, in about that order. Okay? And we're going to go right to target trial emulation. Okay, great. All right, we're already, we've hyperspaced. It's a common theme now with Cosmos. Hyperspaced in slide 99, if you notice that. Slides are not noted there, but okay. Who here has access to Cosmos? You do?
No, but hypothetically, everybody.
Hypothetically, okay. Sean?
Not the back end.
Okay, the front end. You have Slicer Dicer?
Yeah.
I'm all here?
Same. I have the same. Just
You have Slicer Dicer?
I don't have your data shelter one.
Dr. Espinoza here? She has full access. Rachel? All right. So it's very important. If you get on the pathway to gaining Cosmos access, please make sure you understand what it is you're trying to get to. There is Slicer Dicer, which is information that is not really row-level data. It's aggregated data. And it provides nice snapshots of different disease processes, but it doesn't provide capacity to really write manuscripts that are especially incisive. Okay? You need to get the data architect or data science. We talked about this last September. In order to use Cosmos, you have to create a data mart out of multiple table structure. And there's around 130 tables inside of Epic Cosmos. And you all work with these tables every day. Vital sign tables, temperature tables, medications, which are in tables, order medications, and then patients go to pharmacies and they're dispensed. Those are two separate tables, dispense and ordering. There are birth tables, so connected mothers to children in birth tables as well. And you do queries. The most basic query would be selecting different columns from a specific table. And you're joining characteristics that are common between them, between one table and another. The overall scheme of Cosmos is the star schema, which is essentially the same way that structured query language and table structures have been set up for the past 50 years across the country. If you work in any Fortune 500 company, you have data inside tables, and those data is accessed using SQL. The star schema essentially in Cosmos involves fact tables and dimensional tables. A fact table is something that happened on a certain day. Right? So if it's time and date stamped, that is a fact table. Dimensional table is a table that is always true. It's true. It was true 5 years ago. It's true today. So if an operation has a certain dimensionality to it, it has a description, it has a CPT code, it has a simple description and maybe a more complex description. And it's inside ICD-10, ICD-9, maybe CPT, so all these different codes have categorization. Those are dimensional tables. So procedure event fact. So you had a patient with pancreatic duodenectomy. And so you would want to look for patients who had that operation done. Or you probably want the diagnosis first. Patients admitted to the hospital with gastrointestinal bleed. All the patients with a prealbumin under 30. And you would put those into your catchment of all patients with that disease process. And you'd have to look for labs maybe in the 3 months before and up to that hospitalization. Right? And then afterwards, you would look for outcomes of interest in the time windows of interest, 30 days, 60 days, 90 days. And in between, you have to figure out what procedure was done and whether a procedure was truly done or TPN was administered. Be able to access both of those pieces of information. There are ways to gain access to the various columns. There's lots of tools inside Epic Cosmos for helping you understand what the structure is. But at the end of the day, you are combining tables on characteristics that are common between one and another table. The joins, and it seems just so complex, but Sean, did you ever get to these joins? You probably never did with the SQL.
I did not.
So the next course would have been, or the next testing scenarios would have been inner joins and outer joins and all the different commands used in SQL to create a data mark. And the NIS, the NRD, those data structures are essentially data marks that have been pulled together by sophisticated SQL queries. So I embarked on a look. I also do pediatric obesity surgery. And as a way of discussing and thinking about Cosmos and its application, I thought I'd review a case, and this is a case that I've been working on with the pediatric obesity team. Dr. Linden has been helping out as a first author on publication, but the FDA approved semaglutide for obesity in adolescents 12 through 18 years of age in January of 2023. And so I was curious what the impact of that would be on obesity surgery, on just obesity treatment in general. And so when we think about a study like that, what types of things would you like to define? Ted, have you thought about these things?
Outcomes for pediatric.
Yeah, just in general. So if I was to do a study on semaglutide, how would I think about putting together a study like this?
I want to look at primary outcomes of weight loss by either
Okay.
pounds or BMI change
So you want an outcome of interest. Okay.
and safety, contrasted with safety.
Which is other, so good outcomes and bad outcomes. Okay. So you have, and so if you were picking a primary outcome, what would it be? There's no right answer to this. I mean,
Yeah, I think weight loss by BMI change.
BMI change, okay. So percent BMI change or absolute BMI change. And which I think is a very reasonable approach. Could we also do percent total body weight loss? Just weight loss in general. Yeah, do that. Any other things we could do? Hemoglobin A1C change?
That's a reasonable outcome.
Kids are not going to have diabetes as often. If we're looking more broadly, it's not going to be as useful. If we were doing a diabetes study and we only were catching all the patients with diabetes, that might be a good approach. Okay. All right.
Would he track their height as well, or so they're, because if you said 12 through 18, you're going to catch them through adolescent growth spurt. You do see children suddenly stretch
You're
out.
hitting some questions right now that are very active for me. Very, you can't
They're
believe how
growing
active
and
they are.
changing, so sometimes rapidly.
So, yeah, so I'll get back to height in
Just
just a little bit.
thinking.
Yeah, exactly. That was a question that we were posed yesterday by Dr. Fox, our pediatric obesity expert. So, okay, now what windows are we going to look at? In a study where you are doing observational work, are patients directed to come to clinic at a certain time? Yes or no? Are they directed in an observational study? They're not directed. Okay. So you can't tell them when to come in. And so if I were designing a randomized clinical trial, I might say, I want you to come in at exactly this window. We're going to check all your anthropometrics. Okay, we're going to get everything. We're going to check your height, your weight. You're going to calculate your BMI. We're going to know all your labs. And then we're going to define the windows up front for follow-up. This month, this month, this month. With observational data, you can't do that very easily. So you have to set wider windows. And that's for sure a weakness of observational and retrospective work. What window would you want to define? Ted, I'll come back to you. I've been thinking about this now for at least 8 minutes. So, so how are you going to define the window of time when a patient would qualify to be in this study? Semaglutide was FDA approved, essentially, we'll say December 22, but let's say January 1st of 23. We can start looking at patients who had semaglutide. But their baseline, are you going to do the same day as that? Or are you going to do maybe up to 3 months before or 6 months before? Or how is that going to work?
I think if they have a weight the day of the reasonable baseline,
Okay.
um,
What if they don't?
children, I wouldn't want to extend more than a few months, 3 to 6
months?
even 6 months if age down to 12.
12 to 17.9.
So a lot can change in 6 months. So probably 3 months pre.
What if I told you that we also need a control group?
You can have a control group in the same time frame. Have the medication. I'll have to look earlier for that.
True. Okay, I'm going to go to Jam. Tell me, how are we going to define the dates of intervention here? If we're looking at different things, now I'll tell you right now, we're going to look at doing nothing, doing semaglutide, or having surgery.
So I think I agree with Ted. The date that they get the appointment to get the semaglutide is a good first baseline point.
Is that a prescription or the dispense?
I would say I would do an intent to treat. So the day I write the prescription.
Prescription.
Um,
So you've written a prescription, and now you're anticipating that they are going to get a dispense,
yes.
and you think that's going to be true.
I hope that with every prescription I write, yes.
Hope is a strategy. That's right.
That's one of the 4 strategies.
That's one of the 4. That's right. That's right.
So that would be one of our trial arms.
So your intention to treat is prescription.
Yes. The day so for
Does
that
anybody
arm,
else want dispense instead of prescription?
I want them both.
You want both.
I want them both to compare them.
What if I told you that not everybody who has a prescription gets a dispense,
I would say that's amazing.
but you are going to have more prescriptions than dispense?
How about refills?
Refills another one.
Refills means you actually took it and you're coming back,
You're coming
right?
back.
So you,
A
even not
refill
everybody.
prescription or a refill dispense?
Well, that's what I'm saying. Not everybody who has it dispensed actually takes it.
That's why they created statistics.
So it's complicated, isn't it?
But this is a retrospective study. This is not a prospective or a randomized clinical trial. We don't do intention to be on retrospective usually. So you should just do fill because you're trying to capture what actually happened, and there's a lot of variables that you cannot control.
Would you not want to capture the greater body of those who had the prescription?
I mean, that could be like a sub-analysis, but you're trying to compare people who got the medication, people who got the surgery, and people who didn't. So you're trying to control all the variables that you can.
But if you write a prescription, you are intending to treat.
Yeah, but that I don't think
You don't
that,
care about that.
I don't think that is relevant in the final analysis because you're trying to compare these outcomes. You're not trying to compare.
They make
I can explain this perspective.
You're actually always doing an intention to treat.
It's fascinating. Okay, so now let's talk about.
Especially for a medication that's so expensive and many times that it's written, it's unable to get filled.
So let's say you have a primary
Wait,
care.
what did you just say? I didn't hear it.
Especially in a medication that has many insurance coverage issues and is expensive, I think it's more common for this medication than the average to not actually get dispensed.
You think that's true?
Yeah.
I think so, yes.
Possible. Yeah.
That's where you can try to figure it
The doctor.
So you do want to include them
This is another.
out. It's a separate group.
as a separate group. So no, wait. You're proposing 4 arms of the study, or okay, 4 arms?
I'm greedy.
You're greedy. Yeah. Okay. What about this control group?
So I would capture patients. There is a ICD-10 code for encounter for weight management that can also be added on to a well child check.
Okay.
And so I would capture those patients who did not receive a referral to a bariatric surgeon or a prescription for semaglutide and use those as my control
So
arm.
one problem inside of Cosmos, we don't actually have just orders in general. They don't have a table that has all orders. So if it's referral to bariatric surgery, i.e. the prescription for bariatric surgery does not exist.
But then the
Nor
other,
does the prior authorization request for surgery exist. And that is actually a problem in
age group, there's no well child checks either. You're done. And the only reason you go in is for your sports physical or if you have an illness. That way they can charge for it.
All right, what is our follow-up time frame? How far do we want to look?
I would look as far as I can, right? So
Up to
December
3 years.
2022, and
You
then
want to look 10 years?
Up to
5
3.
years?
10 years doesn't exist.
Up 10 years doesn't exist. Thank you. Okay. 2022, 26 minus. Okay, hold on a second. 26
We're
minus
at 3.5.
23. We could go 3, but we're only going to capture the people in the first 3 months or 4 months now, right? It is live data, right? So we would have data from like say May 1st now inside the data set.
Can I just make a point?
Yes.
This is real world data. So you're picking December 2022.
True.
That's FDA. People were real world doing anything. So I would go back to the beginning of semaglutide approval. You're going to have kids that are,
You're talking about adult approval, which was June of 21. So going back another bit of time.
yeah, I would.
But then what time frame for follow-up?
4.
Up to 4 years now? But are we going to do a 4-year study, a 3-year study, a 2-year study, a 1-year study?
Do multiple and keep publishing.
Just keep publishing.
You look at it every another year.
All right. And
turns out it's
I'm going to talk a little bit about target trial emulation because I know that time is running a little bit short here. So this is an active piece of work. I think we started looking at this about 5 weeks ago, 6 weeks ago. Wasn't too long back. And we actually did a search inside Epic Cosmos for all, basically all kids who qualified at some point, at any point in their life, to have bariatric surgery. So that the disease that would be addressable by doing nothing, by having a prescription for semaglutide or a prescription for bariatric surgery, or an actual bariatric surgery. And in looking at this, I think we had around 5 million patients initially, but then had to readjust because we needed them to be 12 to 18 years of age on the day of their index. And we defined index based on a prescription or a surgery. And for the group that had nothing, we gave them a random date. And the rationale was simply to capture a do-nothing time frame. We then chose this is controversial, 6 to 18 months as follow-up. That's a really long time frame. Why? Why did we pick that time frame? Dave, you're shaking your head, yeah. 6 to 18 months. If you were doing a randomized clinical trial, would you say we're going to follow up at 6 to 18 months?
Usually do sooner.
You could do within a week of 1 year, or pick, they pick 16 months for most of the trials, or 68 weeks for a semaglutide clinical trial. Same thing for tirzepatide. Those are based on FDA guidance in back and forths with drug companies. We chose 1 year as essentially the outcome, mainly because it hasn't been published. No comparison efficacy has been published on semaglutide versus surgery versus nothing. And so
In
we
any
thought
age-
that would be a good first step.
In any age group,
It
has been published in children.
depends on how you think about it. In children, for sure. In older age groups, and I had some of those in the other slides, 50 through 100 slides. There are data in adults based on older versions of GLP-1 medications, where the studies have some semaglutide and tirzepatide, but not all semaglutide or tirzepatide. So, we could have done 9 to 15. I wanted to use a broader catchment because I wanted as much outcome data available as possible. The tighter you make your intervals, we could go, 7 to 17. We could go 9 to 15. We could go 11 to 13. If I had the outcome window 11 to 13 months, I think that I would drop my outcome availability probably by half. And why doesn't a patient show up when they're told you're supposed to show up in that time frame? Clinicians are not available, others are not available. And so there's a lot of different reasons why a patient doesn't show up exactly at that time point. They may be out of town, they may be in school, maybe they do all their follow-up in the summer or in December, depending on the situation. And you can always do a sensitivity analysis afterwards. And that was the reason, to Dr. Acton's point about wanting everything, on everything. You can always look back and say, well, what if we moved it to 9 to 15? What if we moved it to only dispense instead of prescription? We've talked a little bit about the problems with randomized clinical trials. Sometimes it's unethical, they can be very expensive, they're essentially impossible to address the situations, or maybe they won't be available for 5-10 years. So with found data, you can design the trial you would like to know the answer to, as long as you set it up the right way and think about causative inference. And that is really the challenge, is how to think about causative inference. Certainly the biggest problem we have in observational design is that we have confounding. We also have non-overlap of populations. So a population that does not have semaglutide or tirzepatide is going to be lower BMI. Patients with a semaglutide prescription are going to have a medium range BMI, and those having surgery are going to have a higher BMI, most likely in that order. And so you can only really do target trial emulation in places where there is overlap of one population with another. And on top of that, you really need to write out a trial up front. And you can't start to change things over time. And this is actually a pretty important principle here. So when we discuss a trial up front and we say we want to do a trial where we look at percent total body weight loss. And then we get a critique on Memorial Day that maybe we should do percent BMI loss instead. It actually becomes a bit challenging because you have to reframe the entire question. And now you've also violated your intent to study. Your upfront plan is completely messed up. You can still look at it using sensitivity analyses and see if there would have been differences. I'm going to try to hit some of the highlights. There's all kinds of stuff on target trial framework, and if you turn in a paper that is target trial emulation, the questions are going to be about immortal time bias, about confounding by indication, outcome mismatch, all kinds of biases that can still be present. How you pick your estimand is going to be critically important. And then also different problems with pathways of care and pathways of expected follow-up. In the bariatric world, we tell patients they have to show up at 6 months and 12 months. We're going to get a 12-month follow-up, probably higher frequency. Then semaglutide follow-up where a prescription doesn't have a defined follow-up afterwards. There are 7 components of every target trial. I want you to remember the number 7. The actual details you can look up and see as you're moving along through a process of framing up a study using target trial emulation. But when we design studies, it's all about target trial and strobe. And if we use those 2 basic frameworks, we can have a manuscript that's going to be accepted at a higher rate. So eligibility, we talked a little bit about that. Strategies for treatment, assignment of procedures, the follow-up period. You saw we chose 6 to 18 months. We actually qualified patients and pulled covariates in the 0 to minus 365 time frame. I went back a full year because there could be some things that sort of percolate in. Patients having bariatric surgery are oftentimes under the care of clinicians for a year, 2 years, sometimes 5 years, even 10 years. And diagnoses can be present during that period at any point. Primary outcome, that is the focus really of any of these studies. You have to set that up front and stick with that, even though there will be requests to change that, to have moving target. You could, if you pick 10 or 20 different primary outcomes and choose the one that does show the difference, there are problems with your protocol and study design. And then, how do you set up this causal contrast? You need the non-overlapping patients need to be in different parts of, you need to be excluded when you're looking at the overlapped piece. And so there have to be some different ways to analyze and consistency in how the analysis is done. This is what we essentially did. We looked at those 12 to 17.9 years at the index date. Now, we don't do a search in the demographics for all patients 12 to 17.9 years of age. We have to first see if patients are eligible and if they had surgery or a semaglutide prescription. And after all that's been assigned, we have to go back and clip off the patients who were not inside 12 to 17.9. It is a little bit complex to think about that. They couldn't have prior bariatric surgery. They didn't have GLP-1 in the year prior to their index date. And then There's a lot of things here, a lot of detail on our different strategies. So I talked about semaglutide, and it was essentially the first qualifying prescription of 28 days or more for semaglutide, and that was intention to treat. And that has implications, has a lot of implications. We found 17,000 patients with that. The second strategy was having a sleeve gastrectomy or a gastric bypass. It was at about 95% sleeve, 5% bypass. Those index dates went back a little bit further in time because we wanted to capture enough patients. And that was 2,083. And then we had a very large untreated population. So they were eligible to have a treatment, but did not have a treatment. And that was 237,000. 92% of the entire population was untreated. And then these are some other principles. I want to get to some of the outcomes if I can. This just emphasizes the follow-up period. You have essentially your index date on the far left, and then you have this very broad catchment time frame. And literally, the end of the catchment time frame is 3 times larger than the beginning of the catchment time frame, right? So half a year, 3 halves of a year. It's a lot of variability in that. We were trying to get the 365-day as our main target for the catchment. And then we used percent weight loss, percent total body weight loss as our primary outcome. Simple to calculate, doesn't depend on height. We got asked about height just yesterday to address your concern, and it turns out that the patients having bariatric surgery actually lost 0.2 inches of height in the pre to the 1 year time frame. And the patients in the semaglutide group gained about the same amount of height in that time frame. And if you throw those calculations into your percent total body weight loss, it's not going to change anything essentially.
Because from the practical standpoint, you're not capturing probably maybe 13 and 14. Well, you're catching your group has probably finished most of their growth spurt.
That's probably true, and there's a female preponderance, probably 2/3.
So they're done growing typically by the time you're even eligible by age 12.
Correct. We did look at the minimum and maximum. The minimum was a -1 inch change, and the maximum was a 7-inch change. And so there can be quite a bit of growth in the time frame.
Too bad there's no way to get body composition, right? Because that's what many people who lose weight also gain muscle mass, which would change their BMI, which would narrow the BMI effect if they gained some muscle mass while losing some fat. But if the body composition change is really favorable.
When that shows up in Epic Cosmos, one of you guys needs to be on it, okay?
Too bad there's no way to get any data like that.
The moment that column shows up, like all of these things, you'd love to answer. The question is, what is the data, or do you have to do that prospectively yourself? And so the estimand that we predefined was a percent, a difference in the percent total body weight loss between groups. And we thought that would provide us with a nice way of thinking about it. We knew up front that there was going to be an overlap problem. I'll show you the overlap problem here. So this is the overlap problem in general. This is from a different study. This is from the Cleveland Clinic study where they saw non-overlap this is not overlap with that, and this is overlap region. So you can do propensity score matching on overlap regions. You can look just at patients inside the overlap region, and that's where the causative inference analysis can be done. It's in the overlap, not in the non-overlap. Problem with overlap is there's a dimensionality to it. This is, let's say this was just on pre-index weight distribution. But then there's the gender piece, and then the age piece, and the number of comorbidities. And when you start to add that dimensionality into it, the actual overlap shading becomes very, very, very small. And that's where it becomes more and more difficult to design good target trial emulation. Here are, as an example, the standardized mean differences between groups, semaglutide prescription, and bariatric surgery. And every single one of them is above the preferred range of under 0.10. So if you are doing causative inference analysis and looking at identical groups, the SMD, standardized mean difference, should be under 0.1. So we did a different approach, which was to look at BMI strata, 35 to 40, 40 to 45, 45 to 50, and above 50, and only took patients inside each of the strata and saw differences that were ranging between 20.6% total body weight loss up to 24% total body weight loss. And then used essentially a meta-analysis, random effects pooling of data to come up with 22.1% difference between groups. Right? So if a patient has a weight of 250 pounds pre, and they got a prescription for semaglutide, or they had surgery, the weight loss difference would be about 55 pounds between those two at 1 year. All right, this is one of the main impact slides. Key finding, access failure. So you're right. Exactly spot on. So 56% of prescribed semaglutide patients had no confirmed dispensing. Dr. Acton, this was the killer slide right here.
That says bluff. I gotta go for my next meeting. No, so when we talk about peds, roughly half the children don't fill their prescriptions.
So remember this, 56, and it's not them not filling.
Yeah.
They have no insurance
They
coverage.
can't get it. Correct.
And there's family discussions, other things. 56%.
You know what you might want to do here, Dan, is to, it might be fun to do a sensitivity analysis to look at a prescription for an antibiotic to see what the filling rate is. See what that'd be a fun
For
thing
sure,
to
some
do.
other,
Yes.
So back to the pharmacist. Augmentin is like, or amoxicillin or something like that is $7, right? This is 400, I think.
Precisely, yeah. And that'd be a good thing to put in your paper.
for sure, yeah. We did do some sensitivity analyses on the far left side. So these are, so patients got into this study on the semaglutide side if they got a prescription. And so we did analyze based on intent to treat, but we looked at dispense. And we did there's at least 3 sensitivity studies where patients got at least 1 dispense, and there was still a 20.2% difference. If they got more than 90 days, so now looking at full days of dispense, a 19% difference If they got more than 9 months of dispense, a 17% difference. So there is for sure a dose dependence to semaglutide. Now you can up that even more and say, well, I want everyone who had 365 days of dispense and at a treating dose, 2.4 or 1.7. And do patients get to that? Do they not tolerate it? Are they not instructed by their provider teams to get to and stay on the high dose? Because that's how you're going to get more weight loss. But when we do go to 9 months, the difference is 17%. I think we looked at a little bit higher as well, and there wasn't too much more. At any rate, I thought it was useful to talk about a live look at data. I've not shown you any of the tables that are coming out of this study, but these are some of the data that we're wrangling with right now. And thinking about causative inference, thinking about target trial emulation framework. For sure, and I know Dr. Brunswald asked me to talk about our use of artificial intelligence as well, AI tools. No doubt they are helping with organization of assisting with coding structure for queries, and both in SQL and Python. The university has clarified policies that you cannot use AI for non-public data. And so it's hard to know exactly where this fits in all of that. But for coding, where there is no human data inside, it should be acceptable to use AI sources. Questions? Great. We will be submitting this in 13 days. So it's exciting. Yes.
So one of the challenges with prescription data is that not all pharmacies will be captured, but you'll capture all of the, not prescription, the fill data. Not all the pharmacies will be captured. So you might, miss people where they just get it filled somewhere else. A lot of people will use their mom or dad's GLP-1 just to try it out. We'll capture that. And some people use this online sources that wouldn't go through the pharmacy. One thing that you might want to do for your analysis or subsequent analysis, because I think methodologically this is pretty sound, is use your intervention group as all people that received a fill and the duration of fill. That way you exclude all of those other things. And then you can generate a control group based on that. Just something to think about.
Yeah, I think there's probably about 10 studies that can be connected.
Oh my goodness.
To these data sets. It's very difficult to find an easy way to pull in 253,000 patients to have a study flow diagram that runs in parallel as you are pulling these data in, and then to think about the analyses. We're on Python version 64 of the pipeline, and so it gets a little bit challenging. But there's a lot available inside of these data frames. Thanks.
So there's some of the actually not patients who actively counterpart.
Katie. I got a present for you. Oh my god. That money right? Thank you. Oh, yours. Brett, you want one? They say, oh, I got that dog. Oh, like, a photo with the mom. Literally. I'm so excited. Absolutely. It's so good.